Hi, Omis, and everybody else who is listening in our audience today. Thank you so much for registering for our first Eye on the Expert webinar here with A Cure in Sight. I'm Danae Peterson, I'm your host, and I am joined today with 4 doctors who are thrilled to be talking about some of the newest liver-directed therapies that are available right now to us as uveal melanoma patients. So, just as a heads up, this is going to be heavily metastatic discussion. If that's not a topic that you find that you can handle right now, this is being recorded and you can come back to this at a later date. With that, I'm going to go ahead and introduce our speakers, who I am so excited, and we've been planning this for months, so I'm really grateful to each of these guys for being willing to be on. So first up, I'm going to go ahead and bring on Dr. Sid Padia. He's an interventional radiologist from UCLA in California. Next up, I have Dr. Vincent Ma, and he is a medical oncologist from the University of Wisconsin. If you attended I Believe in Scottsdale, you would have heard him speak a little bit. So thank you again for being with us, Dr. Ma. Dr. Padia has also been on the podcast. So if you haven't listened to his episode talking about Hepzato Kit on the podcast, head back to the podcast or the YouTube channel and make sure to listen. Next up, I actually am bringing in 2 of my doctors. Feel a little biased here, but I'm just lucky to have some really good connections, you guys. So I've got Dr. Kevin Burns from the Providence Mission Hospital, who's also an interventional radiologist. And finally, Dr. Justin Moser, who is the medical oncologist lead in uveal melanoma in the Scottsdale, Arizona area at Honor Health Research Institute. So thank you guys for being here. We are here to have a discussion. So we have a few brief presentations, like just kind of some basic, let's let you know what these therapies are, right? So we talked about puzzling out liver-directed therapies, and we've talked about this webinar as we're going to focus heavily on histotripsy and Hepzato Kit, both of which are FDA-approved therapies. One is specific to uveal melanoma and is heavily interventional radiology focused, and then the other one is more general to liver tumors. So I think I'm going to go ahead and have Dr. Padia go first. If you want to pull up, just kind of give us a brief overview of Hepzato. Like I said before, guys, he did do an awesome podcast, and you can go ahead and you can see that podcast, and you can see a little more in depth, but we are going to talk and just have some good discussion here.
Thanks, Danae, and good morning, everybody. So I'm just going to show a little. Danae asked me to speak a little bit about a relatively new procedure in the United States called Hepzato. So what is this? And you see a diagram here. And the goal of this whole device kit procedure is to saturate the liver with a chemotherapy drug. The drug is called melphalan. It's actually quite an old drug that's several decades old. And this is designed for people with liver metastases specific for uveal melanoma. It's really only FDA approved for that one indication. Now, the difference between, when you normally get chemo, you often get chemo either through a pill that you swallow or through an IV that you get in your arm. This is very liver specific. So all the chemo, about 99% or even higher, goes straight into the liver. And there is probably about 1% of it that distributes in the rest of the body. So as a result, you can give very high doses of this chemotherapy called melphalan into the liver, which can then kill tumors. So how do we do this? This is done under anesthesia in our interventional radiology suite in the hospital. It is completely painless because you are under anesthesia. The procedure itself takes about two and a half hours. And what we do is make a bunch of little pinholes. We barely even use a scalpel. There's no stitches involved. We have to put a catheter, which is think of this as like a hollow bore piece of long spaghetti in your upper left thigh, which you can kind of see on the diagram here. We use X-ray guidance going up into the arteries. Those are the blood vessels going into the liver. And through that, we deliver that chemotherapy called melphalan. At the same time, we want to remove the chemotherapy as it percolates through the liver. So try to picture putting a sponge under your sink faucet, and the faucet's running through your sponge, and it kind of drips out the bottom. And so we want to collect all that because we want to take it out of the body, take the chemo out of that blood, and then reinsert it. So that's what this whole circular loop is. And so we put another small catheter in the vein on the patient's, in this case, on the patient's right upper thigh. We withdraw the blood as it's coming out of the liver. It goes through this circuit, which you can see with these cylinders and this box. What that does is it extracts the drug out, and then we return the blood back into a vein in the neck, again, through another pinhole. So during this procedure, which does take about 2.5 hours, so you get multiple pinholes, and at the end, you basically wake up with band-aids on. And so that's kind of the procedure in a nutshell. You stay overnight. It is, I would say, in general, extraordinarily well tolerated. There's probably a little bit of fatigue for a few days afterwards, and we do have to monitor your blood levels throughout the procedure. But we've had a good amount of experience since April 2024, which is when it became commercially available in the United States, and have had very good success rates. And I'll pass it on.
Dr. Burns, if you want to pull up your slides, I will make it so that you can share yours. Perfect.
You should be able to see my slides now. So
yeah,
I'm
you're
going to
great.
talk about histotripsy, which is again, also a new procedure. This was FDA approved in late 2023, so it's also new on the scene. And this isn't specific just to uveal melanoma. This is specific to any liver tumor. And this is kind of a newer groundbreaking thing because it's non-invasive. So think about if you've heard of, external beam radiation, where they're shooting radiation through your skin to try to target a tumor somewhere. This is kind of like that, but we're shooting ultrasound waves in order to mechanically destroy a tumor. So kind of the options of non-invasive things, really, it's going to be radiation, which uses radiation to kill things. This uses purely mechanical energy. So the tumor is really liquefied. And so it's a completely different mechanism of action. There is one commercially available kit, one commercial available device, which you can see pictured here. So this is done, again, in an operating room, and you are completely asleep for this procedure as well. And that is because this can take some time as well. If you're treating one small tumor, this procedure can be less than an hour, but oftentimes, especially in patients with uveal melanoma, you may have many lesions that we may be targeting all during the same procedure. And so this device here is what's called the Edison. This is made by a company called Histosonics. And so this is a kind of a robotic arm. It has a ultrasound device built in here, so we can see live in your liver. And there's kind of a treatment head here. It's kind of like a satellite dish. And I think it kind of beams all these ultrasound waves into one little focal point. It's about the size of a grain of rice. And so we can use ultrasound to target the tumor. And then on this console here, we kind of program out what the tumor volume is. And then we basically figure out how much energy we need to deliver for your specific body. And then we turn it on and let it go to work. Treatment times for tumors can take anywhere from 4 minutes to 1 hour, really just depending on the size. And we can target multiple tumors, one procedure. I think one advantage here is this is completely non-invasive. That does not mean that it's not without side effects. When we treat one tumor in a patient, you may have pretty little side effects, but oftentimes we're treating many tumors now because we know that this is safe and we can save you multiple procedures. So it's fairly common to have some, pain, discomfort kind of at the site, even though there are no incisions. So kind of a closer look of what this would look like on your body. So a patient can either be laying face up or on their side, depending on where we need to target. This big water bath is placed on here. As you know, if you've had an ultrasound before, they put that ultrasound gel on the probe because you got to get rid of all the air or else you can't see into the body. So there's about 20 liters of water. This water is run through a special filter. It's just tap water, but it takes all the air out of the water, so there's no bubbles anywhere. And that allows direct contact from the treatment head through the water, through this membrane here, and then into your body. There's a little video that will play here, just kind of showing what this is like. Obviously, you'd kind of be asleep for this procedure, but this is kind of what the setup would look like in the room. And so a patient would be asleep on the table. There's an ultrasound here, which we can use to first image your liver, figure out where the tumors are. And then this is the device here. So this is how this procedure would work. Again, generally, this is done under general anesthesia, although we have done some cases without that. But currently, mostly general anesthesia. I'm going to fast forward this video here a little bit. So this is a simulated patient with one tumor. So all these ultrasound waves converge down to one little point here. And like I said, it's about a grain of rice size treatment zone. So your doctor here can kind of guide the size. So they're adjusting the size there. We can use your existing MRI or CT or PET, and we can actually do fusion imaging. So we can load that in and match that up. So the ultrasound will kind of overlay over your imaging, especially if you have a small tumor or one that's hard to see. And then this robotic arm kind of guides this treatment through the tumor. And like I said, if you're treating a 2-centimeter tumor, it may only take 4 minutes once you get everything lined up and planned. But if you're treating a bigger tumor, it could be over an hour. It's really a volume dependent here. So this is a simulation of what would be happening inside. So it's really, think about this kind of like surgery, where it's really cutting and going through and mechanically destroying this tissue. So there's no heat, there's no radiation, which means that we can get very close to dangerous things in your liver, meaning we can treat through blood vessels, through bile ducts. And that's something that we may not have been able to do with other techniques that go directly through the skin. And so that's just an overview of what histotripsy is, and I'll pause there.
Okay, awesome. So I love the visuals and I really think that it helps. I'm going to just add a tiny joke. I had tried to explain Hepzato Kit to a family member, and she told me that she spent the last couple of months thinking that the liver soaking, or this kind of immersing the liver in the melphalan, involved actually taking the liver out and putting it in some kind of a basin. So that was just kind of a fun moment. I figured you might get a kick out of that, Dr.
Yeah,
Padia.
the one thing is, I am not a surgeon, so we don't do big incisions. Everything is done through pinholes, and I tell this to patients. I'm proud not to do surgery.
Mm.
So really, after the procedure, after you wake up from anesthesia, you can go for a walk. There's really no, physical recovery time because everything is. You just get band-aids. It's
Yeah. So speaking of patients, or speaking to patients who have had, either of these procedures, most of the patients that I know have spent at least some duration of time laying down or resting, obviously post recovery. Do you guys have kind of an estimated amount of time, that you anticipate, or does it vary from patient to patient and intensity of treatment?
after the procedure. Typically, after the procedure, you wake up from anesthesia, and we have a bed rest time of about 2 to 3 hours. It's usually fairly well tolerated, especially since you are waking up from anesthesia. And our nurses and ourselves, we have plenty of medications to make people more comfortable, pain medications, a sedative, etc., to ease that. After about 2 hours, you can walk up and down the hallway without any issues.
Okay.
With
Dr. Burns?
with histotripsy, yeah. So if we're treating one tumor or tumors where we're going through the front, so say you're laying on your back and we're treating through the front and we're not going through the rib cage, often this is a painless procedure. Some patients may complain that the worst part of the day was getting the IV when they checked in. We are doing a lot more aggressive treatments now that we have more experience, meaning that we will be treating through the rib cage, getting places we weren't going last year. And that causes some pain because the ribs will absorb some of this energy. We know that we're still being able to treat the tumor, and we will counsel a patient ahead of time, knowing that you will experience pain after this procedure, even though there are no incisions. In general, that is well tolerated. In any patient we do any what's called liver-directed therapy, it's fairly common to have some symptoms that usually start the day following. And we will call this post-histotripsy syndrome, post-ablation syndrome, post-embolization syndrome. It's really your body having a reaction to what is happening inside of your liver. And that means that you may feel like you have flu, a little run down, and that generally will always start within the first couple of days. Usually that's gone by a week, and some patients experience none of these. I think it's really a volume issue. So the more you treat, the more likely you are to have some of these symptoms. But there are no activity restrictions with this because there are no incisions. There's no wounds you need to recover from. In fact, if you were on a blood thinner for some reason, we don't even stop that for this procedure because there are no incisions. And if you are on different sort of systemic therapies, we don't stop or interrupt that. We do this concurrently with all of those therapies. So especially since this is new, although it's getting more recognized now, because we don't have long-term evidence, we can talk to the oncologist and say, hey, we are not going to stop anything you are doing. So if whatever you are doing is working, this is really an adjunct, and maybe this will be synergistic.
Okay. I do want to bring our medical oncologist into this because I know both of you guys have had at least, one or both of you have had a series of patients, or at least some patients who have had either or of these treatments. So some of them, yeah. So I guess I know people who have had, and you've treated people who have had Hepzato and or histotripsy. So Dr. Ma, what are you seeing recovery-wise for the patients that you are, advising to do Hepzato Kit with your team?
Yeah, no, thanks. I mean, our center has actually treated a good number of patients with Hepzato at this point. And so I think what we sort of boast about here is that, we actually work very closely with our interventional radiology team. I think communication between the med-onc team and the IR team is extremely important, especially from that transition period from, post-operative recovery to sort of that outpatient. As Dr. Padia mentioned, the recovery is actually surprisingly fairly good. I mean, fairly minimal. Patients after the procedure are typically discharged, fairly soon, quickly as within 24 hours. And usually the way we do it at our center is, from the medical oncology perspective, we'll actually see these patients 1 to 2 days post-op so that we can actually administer a growth factor. Because we do anticipate after administration of the melphalan to the liver that they do get some of these residual effects that actually affect the bone marrow, and actually can cause, a decrease in white blood cells. So we do administer the growth factor typically on day 2 or day 3 after the procedure. And then, we sort of take over from the med-onc perspective, where we actually monitor the patient's blood counts, typically weekly, anywhere from 2 to 4 weeks post-procedure. But for the most part, I would have to say, when we see our patients after treatment with Hepzato, the recovery is exceptional. There's fairly minimal in terms of pain, nausea, vomiting. Patients actually, for the most part, get back to their sort of normal routine until they get on to sort of their next cycle of therapy.
Awesome. Dr. Moser, what do you have to add?
Yeah, I want to echo, what Vin said is when you think about Hepzato and we talk about isolating the liver and, putting like circulating high dose chemotherapy through it, it frankly sounds a little barbaric, right? And so I think a lot of the times we think, oh, this is going to be rough. And I know when we started offering at our center, we were a little nervous, but I think our experience is similar to that of Dr. Padia and Dr. Ma, which is this is actually a really well tolerated procedure. It is not nearly as barbaric. It's actually very few side effects. But I do think the lying flat thing is probably the biggest issue we have, even though it's a very minor thing, right? A lot of my patients, I think our internal protocols are once we pull the sheaths from the pinholes in the legs, they need to lie flat for 4 hours. And that frankly is just boredom. And it's just fighting that boredom. So some people, most of my patients, like they bring their headphones and they listen to podcasts or they have books on audio or something just to kind of get them through that boredom of not being able to move. But other than that, it's a really well-tolerated procedure, despite how intense it seems kind of on paper or as you describe it.
I agree with
Okay.
Dr. Moser that, the first time before, and I'm the guy who does these, before the first one, I was like, this seems like a lot. And, we're washing the liver with this high dose chemo. I'm very curious and I'm a little bit doubtful as to how patients are going to tolerate it. So the first one where we did, she tolerated really well. I'm like, okay, maybe that was just a fluke. Maybe we just got lucky. And then the second one, third one, fourth one. As the guy who's doing it, I'm also quite surprised at how well tolerated it is because it is quite involved. But the patient recovery, my recovery instructions are this. For example, I have 2 patients coming in on Monday. I say, take the week off of work. That's it. By the following Monday, you can get back to whatever job you're doing, whether you're, working in the office or doing a construction job. You take a couple of days off and you're back to, kind of near your baseline.
So as far as histotripsy goes, then on kind of maybe I don't want to say the other side, guys, because we're not here to pit these therapies against each other. Like Dr. Kevin said, this is kind of the idea that this could be adjunct. And I've had conversations with medical oncologists who are exploring the idea of histotripsy because I know that histotripsy is coming up a lot more online. And maybe that's my fault. Sorry, not sorry. But I know that it's something that because it's newer, it's approached with that level of maybe higher skepticism with the medical oncology teams, even with the newer interventional radiology teams. And so I do want to have just a little bit of some dialogue between Dr. Padia and Dr. Burns about like, have you guys kind of run into this, skepticism, among your team, among the people that you've met, people who practice? I know Dr. Burns is probably the one who has done the most histotripsy procedures. I don't know where your count is on uveal melanoma patients, but I know you've done a good number of them, at least in the last year-ish.
So I'll say, I think maybe we should talk about the indications for these procedures because I think they're different.
Yeah.
Right. So
Yeah,
these are
okay.
not competing therapies. I think they're different. So histotripsy is a focal therapy, right? So if you have a small number of tumors that we can count and that we can see, then that may be a good indication for histotripsy. So if you had 3 liver tumors and we can go in and treat each of them with histotripsy, maybe that is a beneficial therapy for you because we can avoid damaging any of the rest of your liver. So when we do this therapy, as you think these waves go through, they don't damage the liver on the way in or the way out. And so it's really a focal treatment. But if you presented to me and you had if you read in a report, innumerable lesions or small lesions, that is maybe not the indication for histotripsy. And maybe that is where the Hepzato kit comes in. So I think these are at 2 ends of a spectrum of different types of patients that all are uveal melanoma patients.
I completely agree with Kevin. These are not really meant to compete with each other. Someone with a single tumor, I don't offer Hepzato. We have a lot of options for a single tumor. Histotripsy is one of them. We can do an ablation. We can do a Y90 radioembolization. The advantage, or let's say disadvantage, of a Hepzato procedure is that we treat the entire liver. And so we'll give you two scenarios. One, let's say a person has one focal tumor that's 1 inch wide, the size of a golf ball on the corner of their liver. Why would I use any therapy to treat the entire liver if it's one isolated thing? Because we want to save that therapy for if, and hopefully never, but if that patient gets multiple tumors in the future. In contrast, you look at the other side of the spectrum. Let's say most of the people I'm treating have more than 5. And many of them have, and Dr. Ma and Dr. Moser have seen a lot of these patients. They have 20, 30. Sometimes you can't count, or you'll spend 5 hours counting it on a CT scan. And in that case, you need a much more global type of treatment. As many of the listeners know, uveal melanoma is one of the few cancers where 99% of these with liver metastases, it's really localized to the liver. So that's why we make this argument that the liver-directed therapy may help these patients. The Hepzato is designed to treat the entire liver from one edge to the other. It saturates it, just like the sponge analogy. You put the sponge on your kitchen sink, you run the water, and your whole sponge will fill up. And so the indications do tend to be, I would say for the vast majority of patients, non-overlapping between the two types of procedures.
Dr. Moser, I know you wanted to jump in as well. Do you want to weigh in kind of on what you've seen between the two?
Yeah, I think they are kind of different treatments, right? It's a spot treatment versus a whole liver treatment. And, I think the biggest thing we got to remember is having more tools for the liver is the best option for our patients. It's the liver metastases in patients that have uveal melanoma that causes problems. It causes liver issues. It can cause, swelling in the belly. And so having more tools to manage the liver is great. But when we're comparing them, I also think we got to remember that both of these are new and we're still learning a ton. The Hepzato trial was a 50, 60 patient trial that treated patients with predominantly liver-only disease. Now, a lot of us are using Hepzato in non-liver-only disease because, again, we need to control the liver. And with that trial, we have both response rates, how much the tumor shrinks, but also overall survival and progression-free survival data. With histo, which is the newest thing, and frankly cool, it's almost sci-fi, right, of how it uses sound waves to kind of destroy stuff, that was approved for any tumor or any liver metastasis based on a trial of 40-some patients, of which 2 were uveal melanoma. And the primary endpoint of that study was, did you hit your target and did it look dead within 36 hours? And so I use Hepzato, or I use histo. Kevin's treated a couple of my patients now because I do think there is a role for spot treatments, but we also need to be aware of the data. We don't have quite as much durability information about histo as we do Hepzato, although the Hepzato data is still small. So definitely, I think there's set non-overlapping indications. Do I need to treat the whole liver or 2 to 3? But I think for patients who are in the middle, who have maybe 3 or 4 lesions that could get both, my preference is still Hepzato just because we have a slightly more data. Now that could change. In a year, once we get more data, it could be histo's better. But right now, I think of the limited data we have, if it's on the fence, Hepzato first for patients who are willing to undergo intervention, right? If someone says, I don't want anything invasive, but I'm still willing to do general anesthesia, then histo's not wrong.
Both interventional radiologists, I'll just add. So we do a lot of other procedures also. So Sid had mentioned microwave ablation. That has decades of research. And so we have all these other tools. We're talking about 2 of them today, but we have all these other tools. He had mentioned Y90 as well, which have long-term data. There's definitely options that we also have that do have some longer-term data. We're just talking about the cool new stuff.
The nice thing is, so far, we have not found bad interactions with systemic therapy. Because if we did, then it becomes a bigger challenge, right? If I have to take someone off of, I'll give you one example. Let's say I have to take someone off of tebentafusp, also known as Kimmtrak, which is used in almost half of patients with metastatic uveal melanoma. If I have to tell a patient, you have to go off of this so I can do this, it's not that easy of a discussion because, what are you going to do? How do you take someone off this drug and then their tumors, grow rapidly? So as far as we can tell, and it's always challenging with a new therapy because we haven't done 10,000 people yet. I have not seen any or nor heard of any really bad interactions with the standard of care systemic therapies that are used for uveal melanoma. Dr. Moser and Dr. Ma, have you guys seen any bad interactions so far?
No, it's great that you actually bring that up as well, because these are some of the conversations I have with my patients as well when they're diagnosed with metastatic uveal melanoma. We're sort of in that dilemma. Do we sort of focus purely on the liver, or do we need to kind of think of it more of on a systemic level, right?
Mm.
For the vast majority of patients with uveal melanoma, they just may present with only liver disease. And so it may make sense to just kind of focus on just treating the liver itself. But when you're sort of thinking about sort of along the lines of histotripsy, where you're maybe thinking about treating maybe one or even a few number of liver mets, you kind of have to think to yourself, well, what about the other parts of the liver where you can't physically see disease? There's that possibility that there may be sort of microscopic disease where you sort of need to think about incorporating some degree of, systemic therapy alongside it. Whereas Hepzato, you sort of have that opportunity to kind of saturate the whole liver, and you sort of hope that that is the only site of disease that's present, from the melanoma. So, these are sort of the tug and pull and sort of having to weigh the risks and the benefits of choosing either one procedure. But, when it comes to patients, for example, who may not, for example, be fit enough, where, handling sort of the hemodynamic instability that frequently occurs with Hepzato, histotripsy might be a really great option to certainly consider for those patients. In those particular cases, I may, as an oncologist, want to think about also incorporating systemic therapy concurrently. And hearing from Dr. Burns, hearing that, doing histotripsy doesn't necessarily forbid you, or as a medical oncologist, to give systemic therapy is also a very feasible and a great option to sort of hear about as well.
Yeah.
Just to go back to what Dr. Moss said, for the Hepzato, which I forgot to mention, you are under anesthesia, and during the procedure, your blood pressure can vary quite a bit. And so what we do is, before they're even scheduled, they get a stress test to make sure that we're not looking for people who have a lot of cardiovascular disease, people with heart attacks and strokes. You're really not a candidate for this. We want to make sure that you can tolerate the procedure, intraoperatively during the procedure. We want to make sure that your blood pressure can tolerate it. So as an example, if you have an 85-year-old who can walk 3 blocks and then gets chest pain, they're not a good candidate for this. The last thing we need to do is have some kind of terrible cardiac or heart or brain complication from the anesthetic.
Such good points. Okay, you guys, we are getting innumerable questions. And this is great because this means we have people who are really interested in advocating for themselves and who want to learn. So you guys who are on listening, I'm so proud of you guys for being here, for asking questions. We're going to do the best that we can to answer these questions. I am going to say some of them I think we have addressed. I think there's been the question about concurrent treatment with other immunotherapy. That's been addressed pretty well, I think. The general consensus is yes, you can continue systemic therapy under the guidance of your medical oncologist. However, we do have, this question is, can I have histotripsy if I've had Hepzato previously? Dr. Burns, do you want to take that one?
Yes, I will say yes, you can. And it can go the other way also. You can have had a microwave ablation. You could have had Y90. All these therapies can be mixed and matched. Obviously, your doctor will evaluate to make sure your liver is healthy enough to undergo something, but all of these, I think probably a patient could have all of these over the course of a treatment regimen if needed.
The nice thing about
awesome.
all of these is that histotripsy, microwave ablation, Hepzato, none of them cause liver damage. I'll be honest, I was surprised. I thought Hepzato would cause liver damage. You're soaking the liver in chemo. How will it not cause liver damage, right? And every single patient I've had, their liver enzymes are totally normal afterwards. So I was honestly a non-believer until I started doing it. Histotripsy, same way. Microwave ablation, Y90, if done appropriately in the right setting, also does not cause liver damage. So yeah, we're mixing and matching. And the key thing for us to do over the next, let's say, 5 years is figure out how to best integrate all of these. As Dr. Moser said, it's great now that we have all these tools, but we really still are learning when to use option A, when to use option B, when to switch from option B to option A and option C and so on. And the more tools we have, of course, it's more of a challenge to do that.
Well, and this is why we called this puzzling out liver-directed therapies, right? I feel like from the first time I've ever heard Dr. Moser speak about medical oncology and clinical trials, he was always really upfront about talking about how much of a puzzle each patient is individually. And that as an oncologist, as an interventional radiologist, anyone potentially part of the tumor board who is treating a patient with uveal melanoma, these patients are individually unique. No puzzle is the same, right? No puzzle is the same. And to have all of these potential tools, these potential ways to fit things together is such a gift. Anyone have anything else they want to add before I move to the next question?
What about
Oh,
SBRT? Is that talking to Dr. Moser and Dr. Ma? Is that something that you offer to any of your patients?
certainly a good option that I definitely consider. I mean, we have a very strong radiation oncology group here, Wisconsin. And so, oftentimes, before the availability of Hepzato, and even histotripsy, I personally have been utilizing both radiation therapy, but also combining it with immunotherapy. We've done some research over the last few years that there may be some sort of an abscopal effect, meaning that the effects of radiation therapy in one site may actually have an effect elsewhere on the body as well. And so my belief is that, incorporating, if you're going to do radiation therapy to target maybe one or even a few liver lesions, I actually do feel that, incorporation of immunotherapy also makes a lot of sense as well.
Awesome.
Well,
Dr. Burns, can I point out there have been a few questions coming through that are just asking about, the research. And I know Dr. Moser and Dr. Padia, and I think Dr. Ma have all kind of alluded to some of the studies around Hepzato. What can you tell us about what's being studied and kind of the data that's coming around histo? Because I know that's something we all want, right? We want the data.
Exactly, yeah. It's when something's new, you can't have any long-term data. That's how things work, unfortunately. So this received approval based on a limited study of 44 patients, mainly to show that the tumors could be targeted and there were no complications. It was mainly a safety trial as well, because if we had a therapy that was really effective, but it killed half the patients, that's not a good therapy, right? So we want something safe as well as effective. So there is currently a registry going on, meaning that it's not a trial that you can enter, but if you're having the procedure, you can enroll in this trial called Boombox, and that it will be a all-comers trial to collect data on every single patient receiving this therapy at every center. And so that way we can amass a large database of patients and put out some publications on long-term data. There have been probably over 900 patients treated so far in the US in about a year. At our facility here, we have treated just over 200 patients. And so we have quite a big experience of that. And we are running our own internal studies as well to follow up our patients if they don't qualify for the other registry. So that data will probably come out later, but we have to amass, I think it's going to be different based on tumor types. So we treat many tumor types with this. So we need to get enough tumors in each tumor type. So I would say uveal melanoma is just more rare. So it's going to be, there's not as many patients with that versus primary liver cancer or cholangiocarcinoma or colon cancer. So it will take some time for all this data to come out. If we're talking about local control rates, we can say maybe that will be the same between tumor types, but maybe it's not. And speaking on what Dr. Ma has said as well about combining immunotherapy, I think that will be a role here as well, because this is, think about it, similar to radiation, but now we're not even radiating the tumor, we're liquefying it. So it's a cellular destruction, not necessarily a molecular destruction. So there may be some molecules, antigens that are left inside of this cavity that with an immunotherapy may provide this abscopal effect, as was mentioned before, that has been shown in animal models. Again, that does not translate over to humans all the time. So there's a lot of unknowns, I think, with histotripsy.
Data about the tumor specific stuff that you're mentioning, Kevin, is going to be key, right? Because kind of rolling it into the last question about radiation, tumors have different response rates to radiation. Melanoma is actually considered a very radiation resistant tumor. It takes higher doses and less likely. So I used a lot of radiation before we had Hepzato and histotripsy. Now, I mean, because we couldn't always do an intra-op ablation or an IR guided ablation due to the logistics and the invasiveness, I'm using much less of that now because melanoma is radiation resistant. And so I think for radiation resistant tumors, these treatments like histo and Hepzato are probably going to be better than radiation. We just need the data to confirm that. Yeah.
So I feel like this goes really well with this question, and it says it's a little of a complex question, but why might someone with ocular melanoma that's metastasized to the liver choose Hepzato over that standard radiation for treating liver lesions? So can we clarify this radiation that you're talking about? Because radio frequency ablation, that's a microwave ablation, correct? And Y90 is, I think, it can be done different ways, but Dr. Padia has talked to me about how it can be done where you kind of explode a tumor from the inside out, or it can be treating a whole lobe of the liver. Is that the radiation that you're talking about, or are you talking about different radiation?
I think the first question was on that SBRT, so stereotactic external beam radiation.
Okay.
To answer the question about, I think this question is talking about more about the Y90 treatment to the liver. And I think why would you choose Hepzato over that? And, Dr. Padia and Dr. Burns, it's more IR data, so they can weigh in as well. I think the data is actually better for Hepzato. The studies for Y90 and uveal are small trials. They didn't necessarily focus on response rates. It really was overall survival. But when you look at the Hepzato data, that had a higher response rate than what we would typically see in uveal melanoma patients for anything really, and survival of over 2 years, that looks better. Now, until we do a head-to-head comparison, we can't really say that, but it looks better. And I don't know what Dr. Padia and Dr. Burns think about that.
Yeah, just to clarify, it ends up becoming a little bit of a word salad, right? So this whole radio or radiation, what is that? So radio frequency ablation does not use any radiation. It actually works by ionic agitation and heat and so on. So we're going to put that one to the side. So when we talk about radiation, there's in the liver, two forms of radiation. One is from the outside in. So you go SBRT, which is stereotactic body radiotherapy, and it goes by a bunch of different acronyms. You go into a scanner similar to what you've had in a CT scanner, MRI, and some radiation beam shines from the machine into your body. So it goes right in, you don't feel it, and it zaps some body part based on computer modeling. So that's external beam radiation, and it goes by a bunch of acronyms. Then there's internal radiation where it goes from the inside. So those are, if maybe even in your eye itself, when you had uveal melanoma, you may have gotten some what's called plaque or brachytherapy, or Y90 is an internal radiation where we deliver radioactive particles inside the tumor through the blood vessels. And so now you have this golf ball size tumor, and then the radiation seeds are in the inside of it. And the nice thing about that is there's no spread. There are, from the Y90 versus the Hepzato, it's a question we're trying to answer now. We're making some progress, but give me about 2-3 years and I'll have a better answer. I'd say that the person who has multiple tumors in both the right side of the liver and left side of the liver, and Dr. Ma made a very important point about 10 minutes ago, there are also, sometimes you see these things, or you don't see them, microscopic tumors that are too small to see on our CAT scan and MRI, or even on our angiograms. If someone, for example, has 15 tumors, in all likelihood, they have more than 15, right? It's just, microscopic deposits here and there. We don't see them because our machines are man-made at the end of the day, and they have a limitation, just like your computer monitor has a limitation in terms of your resolution. So the Hepzato, the nice thing is it kind of saturates your whole liver. The Y90 is meant to be a little bit more focal and targeted. So currently in 2025, how am I doing this in our practice? And again, this is not necessarily the right answer. Just kind of, if someone needs a whole liver treatment, we're leaning more towards the Hepzato, assuming they fit all the criteria. If someone needs a more focal treatment, let's say you have 3 tumors on the right side of your liver, but nothing on your left side, we may consider more of a Y90 procedure where we just target the right side, treat those with very high doses of radiation, and we get very good results. So there's, when I think about it as a Venn diagram where you have like indications for one, indications for another, there's maybe a little bit of overlap between the two. And that overlap is where we're trying to really clear up which one is option number 1 for somebody and option number 2. We're not there yet. I think it'll take some time.
I have a question around the frequency of using these treatments. And obviously we've established these aren't necessarily, they're not comparative, like competing treatments. These are used in different patients for different reasons. But what are you guys seeing as the frequency with which you can use it to treat? So Dr. Ma, Dr. Moser, Dr. Padia, how often do patients have a Hepzato Kit treatment? What's kind of the protocol?
The standard protocol was developed off of this trial called the FOCUS trial. So it's admittedly a little bit arbitrary. And so what I tell people is that you get 2 Hepzato treatments off the bat. They're scheduled, I schedule them in advance, anywhere from 6 to 8 weeks in general. So in other words, today is February 21st. So let's say you get one today, and then you're going to get one late March, early April. Okay. And then what we do is we get another scan, a CAT scan or an MRI, 1 to 2 months later, and see what we're doing. And if we decide to do another round, we do them in 2s, like another 2, another 2, another 2. There's a lot of debate and controversy. And so there's no right answer of, after that first 2, you get in your new scan, do you go to Hepzato number 3 and 4? And as interventional radiologists, people around the country and around the world who are doing this, we're all over the map. We don't know the right answer for that. On the one hand, we want to try to kill as much cancer as possible. On the other hand, we want to be able to stretch these therapies out as long as possible. So we're kind of trying to reach that perfect balance. So I don't have the right answer yet.
Okay, this is the follow-up question to that, and then I'll ask Dr. Burns. Is there like a lifetime number of Hepzato treatments that you can have like based on, you know, the data that we have? Or is it like, for example, if you had 1, 2, 3, 4, 5, 6 in those pairs, maybe they all happened pretty consecutively, and then you reach some level of stabilization. Do you then start the clock over a year later if you present with new disease and now you have 6 more, or are you done with Hepzato? You can't use it again?
So right now, the official line is that you should get no more than 6. That being said, there have been a lot of people who have gotten more than that. It's just that we don't have good data to support or negate the fact that you can get more than 6. And we always have to think about, every time we do this, what is the potential benefit, but also what is the potential risk? So what people have seen is, once you start to get to 6, Dr. Moser talked about the white blood cell count. Dr. Mon did as well, in terms of supporting people with the white, that can get more severe with the further treatment. So if we find out on treatment number 6, wow, your white blood cell count's getting really, really low, then, if I do number 7 and 8, Dr. Moser and Dr. Mon are going to have some problems managing this patient, because they're going to start getting infections and so on, and we don't want to get that.
Yeah, so there is a tipping point to watch for, and that's what Dr. Moser, Dr. Ma, medical oncology teams are helping to monitor that more long term. Do you guys have anything you want to weigh in on, or do you think we can move to Dr. Burns and kind of flip the question for histo?
No, I mean, I sort of agree with what Dr. Padia mentioned. I mean, as of right now, when I educate my patients about going through Hepzato, I usually say up to about 6 cycles of therapy. And the reason I do worry, especially thinking about even going beyond, just 6 doses of it, is, thinking about the cumulative effects of the melphalan on the bone marrow. I've seen, having treated several patients at this point, that every time we go through a cycle of Hepzato, the blood counts get much more difficult in terms of their recovery. And so, maybe perhaps down the road, as we get more data and we see more patients being treated with Hepzato, we can sort of think about the idea of even considering giving more cycles of these therapies, especially, as you said, after 6 cycles, what happens is maybe we give the patients a bit of a break. And then as we repeat scans down the road, do we need to think about giving more of these treatments, especially if they responded in the beginning? Do we think about giving them again in the future? But I have to say, the problem is, as we repeat scans after every 2 cycles of Hepzato, uveal melanoma is a very interesting disease that we actually do think nowadays that imaging may not be sort of the best or most reliable marker to know if patients are actually responding. I mean, we can actually see patients who have disease that's otherwise very stable, but they're still benefiting from treatment. For example, tebentafusp or Kimmtrak, we've learned that the actual shrinkage of tumor actually occurs in about less than 10% of patients, but we know those patients are benefiting from it because they're living longer than patients who are receiving alternative therapies. And so those are some of the challenges we face, especially of knowing how are patients benefiting from treatment, things like Hepzato, and that may sort of help us one day decide, do we need to think about actually giving more doses? This is a big area of research that we still need to figure out.
Dr. Ma and Dr. Moser, you guys got to get working on finding a better, like a blood test or something, a tumor marker. Because I agree. I mean, imaging is archaic, right? Like getting a CT scan every 3 months or an MRI, it's super old school. We need better. And I say this as a radiologist. That should be antiquated. You guys need to come up with a better blood test that people can go to a lab and just get a quick blood draw and tell how your cancer is doing. That's I
want to come back to that.
Agreed.
I want to come back to that because I know Dr. Ma and Dr. Moser have some interesting things to talk about there. But for histotripsy, for the same question, how often can patients who present as a good option for spot treatment and histotripsy, how often are you seeing that you could treat a patient, Dr. Burns?
There's really no limits on this because it is a focal therapy. We do have to be cautious of destroying too much liver at once. So if you presented with, let's say, 6 tumors, 3 in one side, 3 in the other, and really wanted to undergo histotripsy, we would probably stage that therapy, treat 3, let you recover for 4 to 6 weeks and come back. We just base these guidelines on kind of other things we do. I don't think there's really any right answers here. The most sessions we have treated one patient, we've treated many patients over 4 times over the course of a year now. And those are generally patients with multiple tumors. New tumors can show up, but we can go after them. And those patients have had no impact on their liver function as far as we can tell based on laboratory values.
Yeah. We did have a question that I think you answered kind of in the back end. It was just about the AST liver function tests. So AST, ALT, any of the liver functionality tests that those are evaluated. What are you seeing in kind of the normalization of those levels after histotripsy? Because I know some patients experience a little bit of a spike and then it comes back down. I can speak to my experience if it came back down really fast.
I don't know if it happens with Hepzato, but when we do anything to destroy liver tissue, the AST, ALT generally go up because think about those are like made in a liver cell. So if you destroy a liver cell, all that gets released, and so that's what's being detected. So that can, if we measure that on histotripsy the next day, I would hope that it's high because that means we have to destroy something in the liver, and then usually those go back to normal fairly quickly, 1 to 2 weeks. I wouldn't expect them to be elevated for longer than that. We have patients who have baseline, mildly elevated LFTs, 100, 200 AST, ALT, and we have some patients who their LFTs normalize afterwards. I can't explain that. And that may not be specific to but that may be that there is some sort of systemic issue going on inside of the liver where it's maybe helping the liver globally by treating one tumor.
We have
Yeah,
not
it's
seen
super
after
interesting.
Hepzato, your AST, ALT, and then the other ones are what's like bilirubin and albumin are two of the other ones that measure more of a long-term effect. We have not seen spikes, which is great. I honestly didn't believe it. It was one of those things I was like, no, we're going to see a spike because as Dr. Burns mentioned, we're saturating the whole liver with this high-dose chemo. How we're not going to see it. For whatever reason, I don't understand the basic science of it, but it does not seem to, the chemo that's used in Hepzato does not seem to attack the normal liver cells. And I'm sure there are medical oncologists who could explain that way better than I can. And so let's say even the next day when we get a full blood panel, their liver enzymes are basically the same. So that's one thing, fortunately, I don't worry about. What I do worry about is the person who has elevated liver blood tests before the procedure. That is always concerning. Is that a side effect from their drug? Is that a issue because they have too much tumor in their liver? Or are they blocking their bile ducts? Those are the ones where we really worry and debate about.
Yeah, and those patients who have the elevated liver enzymes are the ones that maybe we direct more towards histo or the spot treatments versus the total liver treatment, because it's not necessarily, like you mentioned, Dr. Padia, the drug harming the liver, but is the liver healthy enough to treat them? Yeah.
Agreed.
Yeah. Well, and to kind of add to that, one of the other potentials here is that maybe you're treating with Hepzato, right? And you're seeing good response and there's some good success there, but there's a rogue tumor that just keeps kind of flaring up, or it's just continuing to grow despite everything else responding well. That might be an area where, you put histo or you put Y90 back on the table, but specifically that you try to aim to do something maybe a little less invasive, a little less damaging, with the aim of just treating something unique and, something very specific. This question, I think, is a Dr. Burns question. How many tumors can you handle at once in a treatment? Or does it really, I know this is it's an oblique question.
Yeah, I would say it's more, we have some volume limitations now. So if you had one very large tumor, that may be all we treat. But if you have 5 small tumors, we may treat all those at the same time. I think it's going to really depend on how many different positions you need to be in for the procedure, how long we think this procedure is going to take. Obviously, we don't want you to be asleep the entire day because we can stage these sort of procedures. So I would say there's not really a limit, but there are some complications that can happen with any procedure, and those usually happen when you do too much at any one time. So I would say we want to limit the volume. If you have this procedure, we've seen, especially I'll just generalize to melanoma in general, it's fairly common to have urine changes after this procedure. So you can have dark urine immediately after this procedure. We've seen that associated with very large volume treatments of any tumor type, but we have patients where we treat one uveal melanoma lesion and they can have red urine or dark urine immediately after the procedure. So there is something excreted renally, some of the metabolites or the killed cells. And so we don't want to saturate the kidneys with anything because we can always stage this and do more over time. Fortunately, all that resolves. Usually you just have you hydrate, give you some IV fluids, and usually the next day your urine is clear. And so we can run into some complications that are extremely rare if we do too much at any one time.
Speaking of UM patients, do you have like a rough count of how many uveal melanoma patients you've treated thus far, Dr. Burns?
I don't. I mean, it's going to be in
gathering that data.
Probably the 10 to 20 range.
Okay.
I think it's not that many. And like I said, it's a more rare disease. It may be around the 20 mark now. But again, we've treated about 200 here, and there's been 900 treated globally. So maybe the rough number is, there's no way there's been more than 50 patients in the world treated with this condition so far.
Okay. This is a good question. Would you treat a single liver lesion if it has been stable for greater than 2 years on tebentafusp? I guess this is a global question. I guess, you guys could all weigh in like, yes, no, why not? Would there be, oh, wait, Dr. Ma, this would be a great time to bring in ctDNA.
Yeah, that's a great question. I mean, so I think the dilemma that I would face, especially if I'm going to be monitoring the patients on Kimtrack, right, or tebentafusp, they're on treatment for 2 years, right? But there's this, pesky lesion that we just don't know. Is it indeed, an active or live melanoma? Could it potentially even be a scar, right? These are sort of the situations, I sort of think about as well. Do we need to think, for example, not just even, just doing radiation therapy, histotripsy, or any sort of like focal liver-directed therapy, but maybe even surgery to actually remove it. And then that might potentially be, an opportunity to even render the patient hopefully disease-free. But those are the things I think about as well. But some of the other tools that I've been sort of more so heavily utilizing over the years is actually assessing the patient's blood and actually assessing a thing called circulating tumor DNA. So, as you know, every part of our body, makes DNA as well as our cancer, but our cancer secretes a particular DNA mutation that is very unique to the tumor itself. And nowadays we have newer and sophisticated technology where we can actually detect it in the blood and actually monitor it over time, whether you're using it to monitor and survey patients for cancer coming back, or as an alternative approach is actually using it to actually detect, how that level changes over time while you're on therapy. And so nowadays there's actually a variety of different commercially available CT or circulating tumor DNA tests available. And in my practice, I actually very heavily use this test and actually to assess how well, for example, is Hepzato or any of the liver-directed therapies or even systemic therapy is actually working against the cancer. And so, we've actually had several patients at our institution where we've actually been trending DNA levels over time. And I would say about 5 of our patients where we've actually been monitoring it have actually been able to clearly demonstrate their ctDNA going from detectable at the start of treatment all the way down to undetectable. And so this is still an area of evolving research. And, what does it mean to have an undetectable level? Could that level then come back? This is an area that we still need more patients to accrue to better learn from so we can decide, does it make sense to also monitor patients with ctDNA while on therapy?
And I think we need a standard ctDNA test as well, right? So the ctDNA stuff really came out of the Kimtrack trial, but the assay or the test they used for that trial isn't actually commercially available. It was designed specifically for that study. And in that study, I think it was 20 to 30% of patients who had metastatic disease to the liver, they couldn't actually detect ctDNA. So there are some other clinically available tests that are approved for any immune therapies that we can use, and I definitely try using them, but I think we're still learning a lot. For people who we can detect a ctDNA and it correlates really well, it's super helpful. For patients who their number is incredibly low, can't really trust what the changes are because the changes are too little. For people who it's negative. So it's a great tool if it works, but for those who it doesn't work for, I think we're still learning.
Yeah.
For someone who had an isolated liver lesion that's been stable on Kimtrack, if we knew their ctDNA was positive and is now negative, this is a super gray area, but I would be very comfortable trying doing histotripsy or an ablation or resection or some sort of local therapy, because one of the things we always have to balance is treating the cancer, but also maintaining a high quality of life. And Kimtrack can work great, but it is also a weekly treatment. And being tethered to a clinic once every week for 2 years can take a real big toll on patients. And so, we don't know if stopping Kimtrack in this situation would be helpful or not. We don't, or would be safe or not. But I think it's a reasonable thing to consider, trying to balance both the quality of life of the patient while also maintaining cancer control. It's a difficult situation. It's one of these things where if you talk to 3 people, you'll get 6 answers.
Mm-hmm.
Yeah.
General question, and I did kind of type some answers. I know Dr. Burns has been in the back end typing a few answers to questions as well. Histotripsy, Hepzato Kit, insurance coverage. Pretty sure, Dr. Moser, Dr. Ma, you guys could weigh in on this, but I'm pretty sure from talking to the people I know through the Delcath Systems group that they have insurance codes, like pretty well across the board. They're pretty well easily covering Hepzato, right?
I've had no issues.
Okay.
We have since it's FDA approved and approved by Medicare, to my knowledge, all private. I live in Los Angeles, so of course,
Okay.
wherever you live in the audience, it's going to be a little bit different. But pretty much every major insurance carrier provides coverage for Hepzato, specifically for metastatic uveal melanoma. Keep in mind the device was developed for this. If you have colon cancer that's metastasized, it's way off limits. So We have not had any barriers, and we started as soon as it was commercially available.
Yeah, it's the same here in the Midwest from Wisconsin. There haven't been any actual issues with getting the approval just because it is an FDA-approved treatment. But I would say the biggest challenge I would say is really getting the insurance coverage of the growth factor. I think that's been the biggest hurdle for me oftentimes because it's really dependent on whether you do something that's in clinic versus the growth factor that you can actually take home. So that's been actually the biggest barrier for me, not necessarily the Hepzato kit.
Okay. I don't have Dr. Burns on here, but he was starting to type an answer, so I'm like trying to look and see if he got his answer typed. At the bottom here is insurance stuff. Okay, so Dr. Burns says Medicare is covering, some commercial plans are covering, but there is a lot of denials coming from commercial insurance. So it's one of those kind of frustrating patterns, and I think that KimTrack experienced this as well. Is that and after initial approval, there was a period of time when kind of private insurance, commercial insurance had a little bit more to say about not covering it versus once Medicare, Medicaid got on board, then it became a little bit of an easier process. At least from talking to a lot of insurance people, like in my personal story, that's what I've learned is that it is a process and that depending on the therapy, depending on the approval codes and all of the data that they have at the moment, it can take some time to get that kind of blanket approval for all insurances. And that even if you have that, you might still run into it with stuff years down the road because somebody's, computer acted up in the insurance coding.
And I think just to try to be as unbiased and fair as possible, one of the challenges which Dr. Moser mentioned earlier in the conversation is that, the histotripsy is not specifically designed for uveal melanoma. It wasn't FDA authorized for that. And the published data so far, if you do a Google search and so on, it's not designed for uveal melanoma and did not look at long-term results. So I think hopefully if that data comes, then insurance companies will play ball a little bit. But it's right now, my guess is it's a little bit challenging because an insurance provider is going to say, well, show us the data, right? Because that's how they work. And I don't know if Dr. Ma and Dr. Moser agree with that or not.
I 100% agree. And I think that's why it's important to participate in these registries and stuff that Dr. Burns talked about, because, to get insurances to pay stuff, they like data. But the other thing they like is guideline approvals. Right. So even if it's not FDA approved, if we can generate enough data saying, hey, this works in uveal melanoma, petition the NCCN guideline uveal melanoma committee to say, yes, we think there's enough data to support this. If an NCCN guideline says, yes, we think this is useful, it's really hard for an insurance to say no. But NCCN is data driven. So participate. So if you're someone who's gotten histo, participate in these databases and all of these things, because that's going to make it easier for people in the future to get it if the data is as exciting as we think it is, right? I think histo is going to be a great option. We just need the data to prove it so we can get it on the guidelines and use it more.
Yeah. And you guys, I apologize. We lost Dr. Burns because his internet cut out suddenly and he's been trying to get back on his phone. But I appreciate you guys jumping in and kind of weighing in for histo in his absence and talking about getting back, getting to those registries. That applies to all of us, right? And for all areas of our disease management, like make sure that you are participating in the patient-led registries. We've got the Insight registry led by a Cure Insight. There's other registries led by other organizations that are tracking patient-driven, like natural history data. But then we also have oncology data-driven registries like the one that Dr. Burns is doing. And I'm sure that there's something very specific to Hepzato Kit where you're gathering data as doctors collectively around the country to just know what's happening, what are the best practices and the evolution that needs to happen over time. Speaking of kind of the where's it going from here? We have people from Canada. We've got people from the UK. We've got people in Asia who are just like, well, when is this coming to me? Do we have any indication of like Hepzato making it to Canada? I feel like that's my first question. Anybody know anything about that?
Danae, I don't know about Canada. It is available in Europe.
Okay.
It actually has been available in Europe. It goes by a different name there. It's called ChemoSat, and it's been available in Europe prior to the US. To my knowledge, it's not yet available in Canada, and I don't know the status. And I think there was a Q&A about the anywhere in Asia, and to my knowledge, it's not available in Asia commercially. I don't know if there are plans to do that. The device is made by effectively like a kind of a very relatively small company. So, you can imagine it's not like these guys have a ton of resources to kind of do a immediate worldwide expansion.
Yeah, that makes sense. It is taking time in all of these aspects. Do we have patients like internationally? Are they able to travel to centers here in the US if they wanted to have histotripsy or Hepzato Kit done and they came from, I don't know, Italy or just somewhere random? Is that a possibility? Do we have centers that accept international patients, or is it kind of across the board?
Yeah, it's going to be across the board. I think the one or two challenges, so I think histotripsy is probably more feasible to get for an international patient. The Hepzato kit tends to be more expensive. And so we have had people from outside the United States inquire. The price tag, which is not the physician price tag, it's the hospital price tag, tends to be very high. And unfortunately, for an international patient, our hands are a little bit tied. I, as a physician who works in a very large institution with tens of thousands of people, I have zero control over that. I have no say. They don't care what I have to say about the pricing. So I don't see the bills, which is actually great for me because I don't have to worry about that stuff. And so that unfortunately acts as a deterrent to get Hepzato in the United States for foreigners. So I would encourage you, if you are interested and you don't live in the United States, contact a European site. They are going to be much more, in my personal opinion, more cost reasonable compared to any American site for Hepzato, at least.
I agree. I think if you're an international patient, doing something that doesn't have a direct per patient cost, right? So with histotripsy, a hospital buys a machine, they've already paid that cost. So the cost that they would have to bill for the patient is a little more flexible. Whenever you have a drug, the hospital has to purchase the drug, like Hepzato, and then purchase it for that specific patient. That's not a cost the hospital can control. And most hospitals can't just write off the amount that these drugs cost. And so I think for someone trying to pay cash for Hepzato, it's expensive, even if the hospital is willing to do it for nearly free, because the hospital still has to buy the chemo, which has to be passed to the patient. So I agree. I think doing something that doesn't require a drug like histo is far more reasonable unless you have substantial financial means.
Yeah,
Yeah,
that
I
makes sense.
agree. I guess the only final thought I have to say is, for patients who are very interested in sort of these newer and novel therapies, for example, I mean, for those international patients, it's not unreasonable to think about, participating in clinical trials. As you know, all the drugs we have nowadays had to go through clinical trials in order to get to that FDA approval. And to some extent, some of these trials and drug therapies are covered by the sponsors. And so, Delcath, sort of being the sponsor or the makers of Hepzato Kit, they actually had this available in Europe for quite some time before it came to the US. And so, it's my understanding that, a lot of these Hepzato-based studies might actually potentially be available in Europe. So I would encourage, for patients who are international, if they're thinking about, some sort of liver-directed therapy involving, melphalan liver-directed therapy, maybe at least consider sort of exploring clinical trials as an option.
Mm-hmm. Okay, I do want to end on this note around clinical trials. This is just kind of I don't want to spend a ton of time on this, but I do want this discussion kind of just opened up a bit for patients who have questions about, if I choose to use Hepzato Kit as, a frontline treatment or first line treatment, or if I have a histotripsy treatment, because I'm one of those rare patients who maybe only has one liver tumor and it stays that way despite all of the indication that it should change. Does this change how a patient can then participate in clinical trials? I guess this is maybe a Dr. Moser question.
Yeah, sorry, I was trying to type
Yeah.
into one of the questions in the chat. So right now, yes, for some. So, the major randomized trials right now in the United States for uveal melanoma are the IDEA study and the Replimune study. Both of them do exclude prior liver-directed therapies, be it radiation, ablation, Hepzato, histo, etc. One of them, maybe both of them, do allow prior metastectomy, which means you cut out just one or two tumors. I don't know that for sure. I think one of them does, the other one I don't. So if you do that, you would lose the opportunity to go on those two studies. Now, there is a new randomized study that's coming to the US. We're hoping this will be here in the next couple of months, and that is a randomized study from Inoctura using a drug called roginolisib. And that randomized study should not exclude you, or it should not exclude patients who've had local therapy such as this. So there are options coming, but the two most readily available randomized studies for uveal melanoma do exclude patients who've gotten local therapies at this time.
My
Yeah.
recommendation for patients is talk to your medical oncologist and find out. And if your medical, this is going to maybe raise some eyebrows, if your medical oncologist does not see a good amount of uveal melanoma patients, I don't know, find these two guys on the bottom and fly to, Wisconsin or Arizona or somewhere
Shop
else.
around.
Yeah, I mean, this is one where you don't want to jail yourself, right? Like, because some of these trials are really promising, and if they exclude histotripsy or Hepzato, and you come to me and you get a Hepzato, and I actually ask every patient, like, have you talked to a uveal melanoma oncologist? And I'll even email our guy, even if he's not seeing them. Would this patient be a candidate for the first line trials that Dr. Moser is talking about? Because I don't want to jail on someone's downstream options, right?
Yeah.
So, and as we all know, everybody on the webinar right now, all the participants, uveal melanoma is something that no one's ever heard of unless you have uveal melanoma, right? So, and even medical oncologists, correct me if I'm wrong, guys, 90% of medical oncologists never see uveal melanoma patient, right? So it's not their fault. It's just they don't get exposure to it.
Mm-hmm.
Yeah, it's a rare disease. And I think, Danae, you bring up an interesting point is, sort of how do we decide on sequencing, right? Do I first maybe consider a clinical trial first, or do I think about Hepzato first, right? I mean, I would always say, public service announcement, I would say for a rare cancer like this, the only way we're going to get better therapies is if patients actually participate in clinical trials. There's a lot of misunderstandings about how clinical trials operate, but I think it's important for patients to just talk to their oncologist, learn more about it, better understand what their options are. But, the thing I have to say about like Hepzato, for example, is, you have to have liver-only disease. And if you have disease outside the liver, they have to be definitively treated. The concern that I often bring up with patients, and this is a discussion I have when we discuss risk benefits, whether it's, clinical trial, other therapies, Hepzato, other liver-directed therapies, is if you precedingly receive a different therapy that does well, but then unfortunately the disease worsens or metastasizes outside the liver, then Hepzato may no longer be an option. And so those are the conversations I have with patients. And when it comes to clinical trials, they can be oftentimes labor intensive, and you have to think about the quality of life for patients, how often they have to come into visits, for the treatment monitoring. And so those are some of the aspects and components I often frequently discuss as well. And not every center has clinical trials available. So on some occasions, patients may even need to travel as well, pretty far for them.
No, that's such a good point. Dr. Moser, do you have anything you want to add there?
No, I agree. And, like Dr. Moss said, not only is it spreading outside of the liver, but right now the FDA label for Hepzato says less than 50% liver involvement. Now, I think we're learning that maybe that may not be the case, and we may be able to safely do this, but that's still unknown. So if someone has, 40% of their liver, you have to just watch it closely, and I put people on frontline uveal melanoma clinical trials, but also told them we're going to watch your labs like a hawk. If your LDH goes up or your liver enzymes change or anything, we're going to scan you early so we can transition quickly to something like Hepzato so we don't lose that window,
Yeah, and I'm in agreement with that 50% mark, guys. I mean, I think the risk is that sometimes these MRIs and CTs, they're imperfect tools, right? So the risk is that, let's say the MRI CT says you have, the radiologist reading, oh, well, you have a 60-70% replacement of your liver with tumor. And then when we do the angiogram, we see it's really not 60-70%. It's really 99%, right? And that's the risk. And then it's, doing this stuff is not going to work. And so we've tried to do our best in kind of abiding by that rule. I get concerned when they have a very heavy tumor burden, and I don't know if this is the best option for them.
Yeah. And I will just, because I've heard Dr. Burns talk about this before in just generally around liver tumors, this is where if the liver burden is really high, he and his team and, the histosonics, they're evaluating, how often can we go in with someone who has basically nothing left and use histotripsy as kind of a last option to just try to give some relief to the liver. And they're seeing that, in some cases that can be helpful. It's just, of course, the data is still evolving. Obviously, uveal melanoma, we're still learning. But I appreciate you guys for just talking about this, because I think that this is something we need to know about as patients. Like you said, Dr. Padia, we shouldn't be going into a treatment expecting to then be able to jump right to a clinical trial. And I think the other kind of maybe caveat that I want to add to this, because this can make it sound a little grim if you're feeling like, oh, well, what if I can't get in a clinical trial because none of them have openings right now near me? Because there are limited slots in some cases for, certain trials. So just limitations to the trial being open, or the accessibility of the trial, or maybe you're just not a patient who presents with disease in a way that would be effective to be part of a clinical trial. I know I was one of those people. I had one spot and it just stayed one spot. And then we treated it and I had nothing show up for like 15 months. That's not normal. Like, most people aren't like me. And so I just was a little bit discouraged, I think, as a patient, to find out like, oh, like I thought that I could do clinical trials. Oh, never mind. This one microwave ablation I had almost 2 years ago, that was the one that initially kind of disqualifies me from most of those ones that say you can't have liver-directed therapies first. So, and Dr. Moser gave me some hope. So I want to like give patients some hope that if you choose to do spot treatment, or you choose to do Hepzato first and have some kind of a liver-directed therapy, and then you need something else, are there avenues of compassionate use or expanded access for patients? And how do you kind of figure out that path?
There can be. It's a case by case basis, but also if you get a liver-directed therapy and you get, 2 years or a year, we're constantly changing. New trials are constantly opening up, right? We had discussions at the big Ocular Oncology cooperative group last month about a new trial that could be coming to uveal melanoma this year. And so it's never wrong to say, I'm going to do the liver-directed therapy, because options are changing. And I think that's why it's important to remember what Dr. Padia said, which is connect with someone who knows uveal melanoma. Even if you see them kind of once a year or every other visit to quarterback your care, we know what's coming. It can help direct you there. And we can also let you know what trials are available, because there are some, earlier phase uveal melanoma specific trials that don't exclude you from prior directed therapy. You may have to travel, and that may be a discussion, but there are a lot of options out there, and it's constantly changing. So
yeah. Now, the treatment space is definitely changing a lot frequently. I'm very excited to talk about this COOG meeting that just happened. It kind of happened when I was in recovery, and it was great. So you guys, there's so many good things on the horizon. I hope that those of you listening, you've had a lot of good information. You've taken away maybe some new information, maybe some misconceptions about either of these therapies have been fixed, or like you've gotten better information around them. But thank you guys for your participation. This has been one of the highest participated in webinars that we've had, with just countless questions, and I am really grateful to all of you for being here, listening and staying with us. And of course, to our doctors, Dr. Padia, Dr. Burns, Dr. Moser, and Dr. Ma, thank you guys so much for your time. If anyone wants more information specifically on Hepzato Kit, I did post this on the webinar page, but you can go to the Hepzato Kit website. I believe it's hepzatokit.com. You can also reach out to, I believe they have a map on there where you can find centers that are offering Hepzato Kit near you. You can, of course, also reach out to these doctors as well, and find out if they can refer you to somewhere maybe closer if you're looking to need to travel to find Hepzato Kit. Same with histotripsy. Dr. Burns said to go ahead and share that if you are interested directly in working with him, you can reach out at histotripsy@providence.org. That's their main histotripsy coordinating email. You can also go to the Histosonics website, and they too will have a team of people who will direct you to the centers that are closest to you, because there are rapidly expanding places that are getting the histotripsy machine. I know of people on the East Coast. I'm not going to say names, but in a very well-known East Coast hospital, they're getting the histotripsy technology. It's already here in Arizona. So it is expanding, and like that, or like Hepzato Kit, like the access to it is growing. So I love that we have these to use. And I just want to thank you guys again for being part of this webinar.
Thanks for inviting me. This was super fun. Hopefully people found it informative and helpful.
Thanks, everyone.
Thank you. Yeah, and Dr. Burns says, sorry, we tried to get him back on and the internet didn't want to cooperate. So, but thank you guys. And if we have any other questions that come in, I will make sure to reach out to these doctors and just get some better answers if I can. But with that, I'll go ahead and dismiss our panelists, and we will head to the rest of our days. This is being recorded, so those of you who want to catch the recording later, rewatch it for your own purposes, or just share it with a friend, please make sure to look for this on our YouTube channel and subscribe, and on our podcast where you can listen to it as well. But this is definitely like a listen on YouTube, because you want to see the visuals. So we will see you guys later. Have a good, wonderful weekend.